Okay. I think, are we all here? Oh, is everyone here? I think so. Everybody's here. Lovely. So hopefully you'll get some good use out of those books. Particularly the malaria images is what we're going to be looking at today. So those photographs are really good quality. The lady that writes these books has worked in tropical countries her whole life, and she's produced a series of bench aids almost for all of her life. And this is the latest edition, which is a kind of nice booklet. It used to come as separate sheets. Some of you may have come across them on your travels. This one is a nice booklet. We like it because it's wipe clean. Yeah, so when you spill your Giemsa or your feces, just wipe it clean. But you'll see in there it's got all the eggs and things that we were looking at yesterday, and so it'll help you today. And there are some trypanosomes, so in the practical class later in the week you'll be able to see them. So hopefully that will be of use to you all. I've also given you a handout that has some images again, because what we're going to do this afternoon is think about the morphological diagnosis of malaria. So I'm going to spend some time going through the different features. So today we'll look at some blood films, and then tomorrow you're going to have another practical where you're going to be looking at malaria again. So this is just a kind of the start. So you'll look at malaria over the 2 days. Okay, so tomorrow you'll be making the films and staining them. Today we're just looking at pre-prepared films. So why am I coming and talking to you about malaria? Why me? Well, part of the work I do at the London School is that within our faculty we have Public Health England Malaria Reference Lab. So we are the national centre for malaria. So all of the malaria cases are notified to us that come into the UK. Obviously, it's all imported. So we actually see quite a lot. I'll show you how much malaria we see. So I look at malaria in my day-to-day life. So even though I'm sitting in the lab in London, I'm seeing lots and lots of malaria, which is why I love teaching malaria diagnosis to students. And it's part of the reason I've come to do the malaria with you. So that's why me. Now, I know you've had some lectures on malaria, but I think it's always worth just recapping some of the names of the stages we're going to be looking at in the blood. Because when I'm talking about the gametocyte and schizont, I want you to just remember where that is in the life cycle. So this is just a recap. And then we'll move on we'll look at numbers of cases, compare maybe number of cases here to those that we see in the UK, and then we'll look at some of these features. And then I've got lots and lots of slides for you to look at to get your eye in to diagnose. So, malaria life cycle. So this part of the life cycle is in the mosquito. So the mosquito here, taking her blood feed, injecting in the sporozoite stage, which very quickly goes into the liver. Okay, so we don't see sporozoites in the blood. So the sporozoite penetrates the liver cell and it starts to divide, and it divides and divides until the liver cell ruptures, releasing lots of new parasites. So that could be somewhere in the region of 30,000 new parasites just from one liver cell. So these parasites come out of the liver and have to get into a red cell, because in the red cell they're going to feed on the haemoglobin and start to grow. So once they're in a red cell and they're a feeding form, we call them trophozoites. Okay, so a bit like an amoebic trophozoite. It's the same term. It means growing and feeding form. Okay, so trophozoite. And they are often referred to as rings, particularly when we're thinking about Plasmodium falciparum. You'll talk about ring forms, but it is a trophozoite. So here, this is our trophozoite, and the trophozoite feeds on the haemoglobin in the red cell, and it starts to grow, and it produces lots of cytoplasmic material as it grows. After a while, it then starts to divide its nucleus. So here at number 12, we've got just the beginnings of nuclear division. As soon as you have more than one nucleus, we call this a schizont. Okay, so schizont is a dividing form. So the schizon will divide, cytoplasm continues to grow until it reaches its maximum, and that will depend on species. It then causes the red cell to rupture, out come the new parasites, and enter new red cells, and the trophozoite starts to feed, etc. So this is the asexual cycle. So it's just about increasing numbers. Okay, so asexual cycle. So after a few rounds of the asexual cycle, some of these parasites are going to develop into either a male or a female form. And these sexual stages are called gametocytes. Okay, so either a male gametocyte or a female gametocyte. And they circulate in the blood. And if they are taken up by the next mosquito in a blood feed, they go into the mosquito gut, where they undergo sexual reproduction to eventually produce more sporozoites. Okay? So the part of the life cycle that we're interested in is this part. So we are interested in trophozoites, schizonts, and gametocytes. They're the stages we're going to be looking at. Everybody happy with the life cycle? Yeah? Okay. So clinically, in what patient would you think of malaria? Now, over the last couple of days, I've sat in on the lectures and I've heard that actually you're thinking about malaria for all sorts. As soon as we've got a fever, we're thinking malaria, even when it's trypanosomes or various things. So in terms of clinical diagnosis, we're going to suspect malaria in a patient, either if we're in a malarious area, or maybe it's a patient that's come from a malarious area if we're in a non-endemic setting. Okay, they would be presenting with a fever of any pattern. All right, so although malaria traditionally we think of this 48-hour pattern, we could have daily pattern of fevers if it was Plasmodium knowlesi, if it was subtertium falciparum, i.e. when before it gets settled into a synchronized pattern, we could be having fevers every day. If it was Plasmodium malariae, it might be longer, 72 hours. So we're not too worried about the pattern, we're just more concerned about the fever. So in this patient, we are going to suspect malaria. So if we're doing this from a non-endemic setting, so maybe you're the ID physician and you're seeing your patients coming in, patients that have falciparum usually present really very quickly, most of them within the first month, but almost all of them within the first 3 months. Okay, so they're going to be coming back and presenting to you very, very speedily. But other species of malaria, it could be much longer. Okay, so it might be a month longer, it might be several months longer, it might be years. Now, have you heard about relapses from hypnozoites? So, yep, everybody's familiar with that. So with vivax and ovale infections, we have these dormant liver stages that at some point in the future, after that initial infection, switch on and start dividing, and you have this true relapse. So that can be a year after infection, 2 years, 3 years, maybe 5 years. So they're the more sort of unusual cases. Plasmodium malariae doesn't have liver stages, it doesn't have hypnozoites, but it can have a very, very low level of parasite in the blood that's undetectable by microscopy, and then all of a sudden that picks up. And it's well documented that this could be 50 years after leaving an endemic area. Okay, so malaria is clinically less severe, so you might just have this sort of mild pattern of fevers every so often and maybe headaches, and then it goes away. So malaria could be a long, long time after that initial infection. Generally, though, in day-to-day life, we would be considering it up to a year. That's the sort of average. So I had a look at how many cases of imported malaria you have here in Japan, because I had no idea, absolutely no idea. And I couldn't find much information, I have to say, but I did find this report, and this is number of cases between 2006 and 2014, 557 in total. Now, the mathematicians amongst you will add up these other numbers here, and you'll say it doesn't come up to this total. And I agree, I actually couldn't find in the paper where these extra cases were. But if we look, 557 over this 8-year period, half of them were falciparum. Vivax the next most common. Then we have ovales, malarias. 33 of them were unknown. Okay, so either just diagnosed clinically or unknown. No Plasmodium knowlesi. How disappointing. I thought there must have been one. You've had one? After 2014? In that time? Ah. Maybe before, yeah. The information was very thin. I couldn't find very much at all. Number of deaths was debatable, but they said they thought it was 5 in that same period. So if we compare that to what we see in the UK, we see between 1,500 and 2,000 cases a year. So we see lots of imported malaria, mainly in people visiting their friends and relatives from countries of origin. Okay, so we have a huge population getting malaria. So if you look, this is just kind of average, the absolute figures. But here, down here, the last figures we have, 2017, we had a total of 1,792 cases. 80% of them were falciparum. We see lots and lots of falciparum. Next one, same as Japan, was Vivax, then ovale, then Malaria. 2 Plasmodium knowlesi in 2017. We were very excited just to have them because, you know, they are quite rare. 11 mixed infections, okay, so naturally mixed infections, and we had 6 deaths, okay, from our imported malaria. So we actually see quite a lot of malaria. So where are these patients coming from? Well, if you have a look at the distribution of cases, most of our cases come from West Africa. So here, look, over 1,000 of our falciparums came from West Africa. That's the kind of risky area for our patient population. If we look down here at this part of the world, Southeast Asia, we have very few cases. Now, whether that's reflecting our travelling population, we certainly have lots of people going to West Africa, or it's a bit of how much malaria we have. I think it's probably a balance of both. But I read somewhere that if you go to Southeast Asia, you could expect maybe 3 infective bites a year. But if you go to somewhere in West Africa, you might have 3 infective bites a night. So perhaps it's more on the side of exposure there. So just the numbers of cases, just to show you how much we see. So how do we, in the National Reference Lab, diagnose our malaria? So we ask our submitting hospitals. So patient goes into the hospital, they take the blood, they'll do the primary diagnosis in the hospital. Then the hospital send us blood films and EDTA blood for us to confirm their diagnosis, because expertise in some of the cities and main cities, it's pretty good, but in more sort of local hospitals, they don't see the malaria that often. So it has to come to us for confirmation. So what do? Well, surprise, surprise, we actually look down the microscope. In these days of PCR, we look down the microscope. So we do microscopy. Rapid tests. Well, for us, we're not really thinking about doing a quick diagnosis, you know, a patient there is acutely ill. So we don't use the rapid tests as much as you might do in the hospital where the patient's presenting. Because for us, actually, we've got better methods, okay? We've got more sensitive methods, and we've got the microscopy. So the rapid tests, we have them, but we don't use them routinely. But we do have PCR. So we have 2 PCRs that we run routinely. The first one is a real-time PCR. It's a multiplex PCR, so we do 4 species of malaria, falciparum, vivax, ovale, malaria, and we can have a result within a working day for our real-time PCR. So that's quite good. But we also have a nested PCR. So our nested PCR is we would do a round of PCR amplification with genus primers, and then we take that product and we put it in a tube, 4 separate tubes, one with falciparum primers, one with ovale, one with vivax, one with malaria, and then we run it out on a gel. So this nested PCR is our gold standard. we can only do Plasmodium knowlesi at the moment on the nested PCR. So that's what we would do for knowlesi. And we also have LAMP. Are you familiar with LAMP? Yeah. Okay, so we have a LAMP. We've got two different LAMP methods. They are both commercial. So the PCR methods are in-house. They're methods that we've taken the original method and developed it for our platforms and for our particular need. The LAMP we buy off the shelf. One comes from Icon here in Japan, and that does Plasmodium falciparum and non-falciparum as a diagnosis. The other one is called Illumagene. This is quite new in the UK, and that one just does Plasmodium species. Okay, so we have LAMP. The beauty of LAMP, of course, is you can have your result in 40 minutes. So this one is our LAMP. So if we're having real time, we can get a result in the working day, 40 minutes. This one takes 2 days. I have to incubate it overnight. So the nested PCR is much slower. So what are the sensitivities? Well, we get very good sensitivity with our thick film, but then we're experts. We look at a lot of malaria, okay? Generally, RDTs and thick films are about the same, okay, I would say in terms of sensitivity. So you're looking at about 100 parasites per microliter. The PCRs, with the real-time PCR, we're getting, for falciparum, about 1 parasite per microliter. With the non-falciparums, it's not quite as sensitive. Now, part of the reason for that is that we weight it for falciparum because that's what we're more likely to find. So it is, that's why you get more sensitivity. LAMP, similar, but here our nested PCR, our gold standard, less than 0.1 of a parasite per microliter. So that is our most sensitive method. But as we've been hearing, PCR can sometimes be too sensitive. You know, clinically, what are we looking for in our diagnostic method? Okay, so we want a diagnostic method to confirm or not the clinical suspicion. That's what we're looking for in our lab diagnosis, isn't it? We want to, are we right? But we also want to know, is this falciparum or knowlesi? We want to know which type of malaria it is. We want to estimate the parasitemia. How serious is this falciparum if we're looking at falciparum? We might want to identify the parasite stage. So if someone presents just with gametocytes of falciparum, it could be that they have some immunity. They might be an adult. It may not be very significant. It may be that they've had successful treatment, so we don't really need to worry about those. If we see schizontz of falciparum, clinically that can be really significant. So we'd actually quite like to know about stages. So which of our methods in the lab does all of those? Yeah, microscopy. Okay, so very much microscopy has I think, a really important role still to play in malaria. I'm not saying PCR is not good. Definitely it has a role. And the rapid test, absolutely, where you haven't got a microscope, but where you have got a microscope, it's really good. Because when we have our rapid tests, we know that even after successful treatment, they're still positive. With PCR, same again. How long does DNA persist? Nobody really knows. It probably depends a bit on the patient. It probably depends on the initial dose, about their immune system. So we may actually not be getting the information we need from a PCR in a clinical setting. Obviously, if you're thinking about surveillance, then it's more appropriate. So at the reference lab, we do that as well. So every sample that comes in, we put through PCR for surveillance purposes, and we're looking at drug resistance markers. We're looking at HRP2 deletions, where it's stopping these RDTs working. And we also use it as a kind of check of our microscopy. You know, it picks up a few mixed infections that we might have missed, but generally we are doing it all by microscopy, which is why this afternoon we're going to be looking down the microscope. So, thin films and thick films. In an endemic area, you're probably going to look at thick films, almost certainly. Do you do thick films in India? Yeah. Cameroon, thick films? Thick films? Yes? Do thick films? Yeah? No? Yeah? Do you do thin films at all? Both? Both. Okay. So lots of endemic areas will be relying very heavily on a thick film because you get an increase in sensitivity. It's a quicker method. But we're going to look at thin films. All right, so this is where we're going to go through all the features. So, how many of you routinely look at malaria first? How many of you are experts at malaria diagnosis? Don't be shy. None of you? None of you are expert, or you're not admitting it. Okay, all right, well, we'll start at the beginning then. So this is a very classic picture of falciparum. Yeah? Lots of parasites in the red cells, loads of parasites. That's what we expect to see. But what sort of things are we looking for? Well, the first thing is that there are a number of parasites. So it's more typical with a falciparum to see a high parasitemia, but not low parasitemias are also important. So we've got lots of parasites. Next thing to notice is that the red cells that these parasites are infecting are all normal size. They look just like the other red cells. Okay? In vivax, we're going to see that they're in different size red cells. So falciparum, they're in normal size red cells. The trophozoites themselves are all perfect ring-shaped. So this is where we sort of think about them as being rings. Okay? They're perfectly neat and tidy and ring-shaped. Okay? There are a few where we have red cells with more than one parasite. Okay? So 2 parasites in that red cell, 2 in this red cell. These are called multiple infections. And multiple infections, more than one parasite in a red cell, are more common in falciparum. You sometimes see multiple infections in other species, but in falciparum, in a heavy infection, we might have 4 or 5 parasites in the one cell. Okay, so it might be very, very heavy. What else can I show you? Right, have a look at this one here. Can you see it looks like it has 2 nuclei? Yeah? So I told you a little while ago that as soon as we have 2 nuclei, it's a schizont. Well, this one isn't a schizont. Okay, this is not nuclear division. This is just the nucleus is elongated, but the way we see it, 2-dimensionally, it looks like 2 nuclei. And these are called double chromatin dots. Now, we all call them headphones. Okay, so this is the headphone form. In falciparum, it looks like, I don't know, your Beats headphones. I used to say Walkman, but, you know, it's a bit old-fashioned. But, yeah, so a bit more modern. These are headphone type. We've also got parasites here. Can you see this one sitting right on the very edge? Same as this one, right on the very edge of the cell. This one looks like it's sort of sticking outside your red cell. These are called acalae forms. Okay, so acalae are these forms that sit on the very edge of the red cell. And they, again, are very typical of falciparum. Sometimes they're called applique. Are you familiar with the English term applique forms? Applique is like embroidery. So it looks like they're embroidered on the edge of your red cell. But acalae form is the term I use, certainly. Okay, so we've got a number of features there. Same size red cell, multiple infections, headphones, neat parasites, acalae forms. Lots of very typical falciparum features. So moving on, going on? Yeah, there we go. This trophozoite is growing and feeding on the hemoglobin. So you'll notice that, again, the red cell is same size as all the ones around it, so we haven't got any change in the red cell. The parasite is growing. So this is the cytoplasm here of the parasite. That's the nucleus. See, the cytoplasm is becoming sort of thickened, but the parasite is still nice and round. So neat and tidy. Now, in the cytoplasm of this parasite are some little bodies. And these little bodies are called Maurer's clefts. Now, Maurer's clefts are actually bits of cytoplasm of the parasite. So imagine that parasite sitting in the red cell and it puts out little arms of cytoplasm out to the red cell surface because it's sort of, it's all to do with transport of nutrients in and out of the red cell. So it puts out these arms. So what you're seeing here are little bits of parasite cytoplasm. So they are a similar colour to the cytoplasm of that ring. Okay, so they look the same colour, don't they? Kind of bluey colour, purpley colour. So because they are arms coming out from the parasite, you just have a few of them. So they are unevenly distributed in the red cell cytoplasm. They're Maurus clefts. Now, Maurus clefts appear as the parasite becomes more mature. However, you don't always see them. They are dependent on how you stain your blood film. So if you use a more alkaline stain at pH 7.2, which is what this is, you would see Maurus clefts. If you use a more acidic stain at 6.8, you may not see Maurus clefts. Sometimes you do, sometimes you don't. So today, you're going to look at blood films at 7.2. Tomorrow, I think your blood films are at 6.8. So it will give you an opportunity to compare the coloration of these two sort of same stain, slightly different method, okay, so that you can detect parasites in both. Okay, so it will give you the opportunity to do both. So Maurus clefts are diagnostic for falciparum. The pigment, yes. We're going to come on to pigment now because pigment is very important pigment, but very unreliable. So pigment, what is pigment? So malaria parasites, as they feed on hemoglobin, they produce a byproduct which is insoluble. Okay, it's a crystalline byproduct called hemozoin or malaria pigment. It's called malaria pigment generally. Okay, so it's hemozoin. And depending on what species we're looking at, it might be scattered throughout the parasite cytoplasm, it might be in a lump, it might be yellow, it might be brown, it might be black. I spend a lot of time in classes saying, can you see the yellow pigment? And most of the time, it's like silence because nobody can see it, okay? But I'm hopeful today, I'm relying on you that you might see some pigment. So the pigment is there, but it is a little bit unreliable. And in a mature schizont of falciparum, we have a lump of black pigment. It clusters as a pigment. Now, do you usually see schizonts of falciparum in the peripheral circulation? I'm getting nods and shaking there. Yeah. Right, saying no. So, why not? So if we don't see them, where are they? The schizonts. So the schizonts of falciparum are very special because the schizonts of falciparum get stuck in the capillaries, in the brain and other tissues. So in someone with cerebral malaria, you will see the capillaries blocked with parasites. Now I think you're going to look at brain section tomorrow. Is that right? Yeah? So you'll see these parasites. And they're all schizonts. It's just the schizont stage that gets stuck in the capillaries, just of falciparum. So lots and lots of schizonts, as they go through the peripheral circulation, would get stuck or sequestered out into the tissues. So it is rare to see schizonts of falciparum, but you do see them. So it depends on your patient as to whether you'll see them or not. So in the UK, we see quite a lot of schizonts of falciparum because most of our patients are non-immune. Okay, so in these serious cases, you can see circulating schizonts. And for every circulating schizont, there's hundreds more stuck in the capillaries. So in terms of prognosis, that could be very serious. You may, of course, be in an endemic area and looking at an adult, and they may have the odd circulating schizont, and it may not be as significant because they have immunity. So don't discount falciparum schizonts from your differential diagnosis because they are possible. So what features have we got? So let's look, there we go. Let's look at the cell. So the red cell is the same size as the ones around it. But here is our parasite, and you can see it doesn't completely fill the red cell. We've got a bit of space. Okay, so this schizont is not filling the red cell. It has a lump of black pigment, really, really dark pigment, and it has 18 to 20 average nuclei when it's mature. So it will have divided and divided to get about 18 to 20. So that is the feature you're looking for. 18 to 20 merozoites, doesn't fill the red cell, black pigment, unenlarged red cell. Okay, those 4 things. Now, of course, you might see this with 4 nuclei or 8 nuclei or 14 nuclei because you're just taking a snapshot when you look at a film, aren't you? So things are always developing. So you need to look at all your features, not just the number of merozoites, but falciparum schizonts, don't be put off by those. And this is the textbook form. This is the one we all want to see. Falciparum gametocytes, okay? So it's beautiful. It looks like a banana or a crescent shape. It is still in the red cell. We can just see the red cell membrane there. It's stretched it right out, almost out to the very ends there, so we can just about see it. It has a nucleus here. This is a female. You don't need to know that, but this is a female. Here we've got some pigment. Again, it's black, but in the gametocytes it tends to be more sort of rod-like, elongated. Textbook, really, really easy. You may also have been told or been under the impression that you have to find one of these to make your diagnosis. Okay, lots of people look for the gametocyte, yeah, I'll find the gametocyte, and then I know it's falciparum. But again, it's going to depend on your patient. So we in the UK, we never see gametocytes of falciparum because all our patients are non-immune, so we're seeing them with trophozoites and maybe schizonts. Again, in an endemic area, you're going to see certainly adults with these, all right? So I will say to people when they're looking at malaria blood films, come along with no preconceptions, yeah? Just look at what's in front of you. Don't think, oh, I need to find that or I won't see that. So, falciparum, fairly straightforward, yeah? You can do it, diagnose falciparum, that will be fairly easy. So we're going to compare it now to Vivax. Vivax preferentially infects reticulocytes. It likes young red cells, and young red cells, reticulocytes, are larger than normal red cells, aren't they? Yeah? So here we have a Vivax parasite, trophozoite, in this red cell. And you can see when you compare the size of this red cell to the ones around it that this is enlarged. So that's the very first thing we notice. The trophozoite, it's not that beautiful, elegant trophozoite that we see in falciparum. This is a bit more untidy. We would call them scruffy, okay, untidy. It's not neat. It looks sort of uneven. So when you look at it, it has sort of an uneven cytoplasm. Can you all see that there are little pink dots all over that red cell? Yeah? These dots are called Schaffner's dots, okay? Schaffner's dots. And again, this is something we see with staining. So you may not see them at 6.8. You may, it's not as reliable. We see them with the 7.2 as a carpet of pink dots. Imagine your red cell looks like a golf ball, okay, with all the indentations all over it. And the stain sort of sits inside the golf ball. So we have this even carpet of Schaffner's dots, okay? Fine pink dots. So the parasite starts to grow, and it's growing in a sort of uneven way. So it's becoming very thickened on one side here, less thick this side. And it's starting to take up more and more of the red cell. The pigment starts to appear because pigment appears with age. The more it grows, the more it produces. And we can definitely see pink dots all over this red cell. Yeah? So we've got this big, colourful, slightly untidy parasite starting to fill more and more of the red cell. Something else Vivax does is it makes the red cells plastic. Okay? They are able to mould themselves around, they sort of curve around the red cells sitting next to them. You can see they're sort of squeezed, they take the shape of the red cells. we say that they're cuddling, okay? They're hugging the red cells next to them because they're kind of moulded. They become very plastic. And that's probably to do with the fact that the red cells are quite enlarged. But again, you can see that these trophozoites are all very untidy, not those nice neat rings. They are all in enlarged red cells, and we've got this fine carpet of Schaffner's dots all over the surface. So this is a developing schizont of vivax. So this is a schizont that is halfway through dividing. So things to notice. Well, the first thing is very obviously enlarged, right? So the vivax goes into an enlarged red cell, and then it makes it even bigger. Okay, so it's making it even bigger. We've got multiple nuclei. We've got about 8 nuclei there. We've got some yellow pigment in the centre. But look how big the parasite is. It's almost filled the whole cell. It's taken up that giant cell. So how do I know that 8 nuclei or 8 merozoites isn't mature? How would I know that? Well, if you look at these nuclei, can you see that they're elongated? Can you see that they're sort of slightly long? When they finish dividing, they look like this. They're small and neat. Okay, so this is my mature schizont, and it has 18 to 20 merozoites. Okay, same number as falciparum, but this time we've got a big cell, a red cell that's enlarged, and the parasite is filling almost the whole cell. You can just see those Schaffner's dots on the very edge. So vivax is a big, colourful parasite. Yellow pigment tends to be quite scattered over the surface. Okay? So the gametocyte, well, all the gametocytes now are pretty boring. Now they're not falciparum. They are all going to be round. So this is our gametocyte of vivax, and you can see again, red cell is particularly enlarged. The parasite fills almost the whole cell. We've got scattered yellow pigment and just the hint of the dots around the edge. So a vivax gametocyte is large, fills the enlarged red cell, just the Schaffner's dots on the edge. Okay, so would you agree? Falciparum and vivax, very different. Yeah, shouldn't be a problem. It all becomes a little bit more tricky when we add ovale into the mix, because ovale looks a bit like vivax. So one thing about ovale is geographically it is localized. So we see most of our ovale, I won't say all, but most from West Africa. And the reason for that, I'm sure you've heard, is that vivax uses the Duffy antigen to enter red cells, so we tend not to see vivax in West Africa because people are generally Duffy negative, and it's been replaced by ovale. So this is what an ovale looks like. So what's the first thing you notice about that red cell? Is it round? No, it's oval, yes? Elongated. So ovale can make the red cell oval or elongated, sometimes teardrop shaped. Okay? So we've got a change in the red cell shape. It also makes it spiky. Okay? Can you see the spikes here and at the other end? Now this is called fimbriation. Fimbriation, finger-like processes. Okay, so fimbriation is typical of ovale. So we've got an oval cell and it's fimbriated. So look at the parasite. So this is a trophozoite, but it's quite neat. So we've got a round, neat trophozoite. It's a bit thicker than falciparum, though. It's not as delicate as falciparum. It's a bit thicker, the cytoplasm, but it's still neat. And you can definitely see we have lots of dots all over it. Now this time, these are called James dots. Okay? So what is the difference between a Schaffner's dot and a James dot? The difference is very small in practice, but James dots are coarser. They are bigger dots than the fine Schaffner's dots. Sometimes it can be a bit difficult to tell. Okay? I think, when I look at ovale, that those James's dots look like they're stuck on the outside. They're so big, they look like they're sticking out, some of them. Can you see what I mean? It makes it look sort of quite rough on the edge. Right, so this is our trophozoite. And this is a developing schizon. So again, you can see that the cell is oval. Okay? It's a little bit spiky. It's got the big dots. Here's my parasite. 3 nuclei, so we know it's still dividing. We're expecting some more of that. Is it filling the cell? No. Okay? So we have a very neat, round parasite not filling the cell. Let's look at it when it's mature. Oh, so this one isn't in an oval-shaped cell. This one isn't a spiky cell, but that's okay, because not all ovale is in an oval-shaped cell. Not all ovale makes the cell spiky, but the other features are still there. We've got dots, and we've got this beautiful parasite not filling the whole cell. So ovale has dots, but unlike vivax, it doesn't fill the cell. Yep, are you with me? It's tricky this now, isn't it? It's getting more complex. How many nuclei have we got? Well, I can tell you we've got about 10. So a mature ovale has 8 to 10 nuclei when it's finished dividing. So half the number of vivax and falciparum. Okay? It's too many combinations now. Right. Look at this lovely gametocyte. I've gone back to an oval-shaped cell because they're so pretty. So here we've got an oval-shaped cell with a spiky edge. But the parasite is still nice and neat and round and not filling that cell. Okay, so ovale does not fill the red cell. Sometimes we may have a little bit of enlargement, like the previous one was a little enlarged, but it never gets as big as vivax. So there's our gametocyte. Okay, so malaria. Now, I understand you haven't been told very much about malaria, but I've just got a couple of key facts because we haven't really got time to go into it. But when I say a cosmopolitan parasite, it makes it sound like it's world-travelled or something, doesn't it? Cosmopolitan. It's not what I mean. I mean, you can see it here all over the world. Cosmopolitan, well, in tropical areas anyway. Longer life cycle, 72 hours, okay? So this is often called quartan malaria. Have you heard the term quartan malaria? Yeah. And do you know the reason why it's quartan? Yeah? So fevers, yep. Longer cycle, yep. Fever on day 1, 72 hours later, day 4. Okay, so quartan. This is important. Often, it's a low parasitemia. Why do you think that might be? Why do you think you might have a lower parasitemia? It has a longer cycle, doesn't it? Yeah. There are a few other reasons as well, which we'll talk about as we come across them, but it has a longer cycle, so it may have a lower parasitemia. This is one, we talked about it before, where we might have these really persistent chronic infections of this low level, just recrudescing every so often. And it is associated, these chronic infections are associated with, a bit excited there, nephrotic syndrome. So this is where you get immune complexes deposited on the glomerular basement membranes. So you get this nephrotic syndrome, and it is associated with these P. malariae chronic infections. So let's look at malaria. Malaria is the prettiest of all the parasites, okay? This is the nice one. But one thing about malaria that you need to know is it likes old red cells. So it will preferentially infect an old red cell. And old red cells are smaller than the normal red cells. So do you have a lot of old red cells in your circulation usually? You don't, do you? Because they're removed by the spleen. So this is another reason that we think the parasitemias of malaria are generally low because it likes these old red cells, and we don't have that many circulating. Okay? So it likes old red cells. Yeah, I don't know. Yeah, you'd think as a parasite you wouldn't want to be in an old one, wouldn't you? You'd think you'd want to be in a younger. Yeah. Yeah, no, I don't know. It doesn't make sense, does it? It's just one of those things. So here we have our trophozoite, and you can see that this cell is slightly smaller than the ones around it. This trophozoite is quite typical of malaria. They are a little bit like ovale. They're a bit bigger than falciparum, but they're nice and neat. But notice that the nucleus is right inside the cytoplasm. We call these bird's eyes, bird's eye rings. And a bird's eye ring is typical of malaria. You can see it in some of the others, but it's more typical in malaria. Bird's eye, okay? It's just a trophozoite. So this red cell, you'll notice, doesn't have any dots at all. So that's something else to take note of. Now, this is a form that everybody knows about for malaria, the band form. So what's happened here is the parasite has stretched itself across the diameter there of this slightly shrunken red cell. Still no dots, but it's gone right across. Now, if it forms a band form, it doesn't then round up again. It stays as a band forever. It will just get thicker and thicker and thicker, so you end up with a really thick band. Okay, so you could have a schizont that was a band because it was a young schizont, so that started as a band and continued. So band form. They don't all do that. Some of them just stay round. But what you can see really very nicely in this is that bright yellow pigment. Really, really bright. So malaria has beautiful yellow pigment here, sort of a yellowy brown. It's all about perception of colour, I have to say, but here we've got lovely yellow pigment. You can see this is quite a sort of, we call this a compact form. So it's very tight, it's quite neat, lots of colour, okay? So it's just a more developed trophozoite. So it might be a band, it might be like this compact form. After this, what happens then is that this parasite then starts to spread throughout the cell. And it may start to divide up its nucleus. So this is a malaria schizont. This is a mature one, and it has 8 to 10 nuclei, same number as ovale. But what do you notice about this parasite that was different to the ovale? Can you see any red cell? No. So the parasite is filling the whole red cell. Okay, so it's completely filling. Do you remember which other species fills the red cell? Vivax. Yeah, okay, so Vivax fills the red cell, so does malaria. Vivax fills an enlarged red cell, malaria fills a small red cell. Okay, so you can see, you can work this out. So this schizont, we can see the merozoites. So here are our merozoites. They're quite large, and in the centre is the beautiful yellow pigment. Now we call these daisies, daisy schizonts, because it looks like a flower. Okay, you need a bit of imagination, but imagine that's the centre of your flower and the nuclei are the petals around it. I have to say, not all schizonts look like this, but hopefully you'll see some today. So a daisy head schizont, very typical of malaria. And this is the gametocyte. So, again, fills the cell, okay, completely filling the cell. We have scattered pigment, a bit like the Vivax. Almost looks like it's not in a red cell at all, really small. These are often mistaken for lymphocytes. Okay. So I'm not sure how familiar you are with your white cells. We might just run through the white cells when we're looking on the microscope, but they are often confused with lymphocytes, which look very much the same. But in a lymphocyte, we wouldn't see all this pigment. Okay, so malaria. All seems fairly straightforward. Each one looks different. Other things you might look for, well, your decreased HB levels. A thrombocytopenia is often something that flags up a malaria infection. But the other thing we see is we sometimes see malaria pigment in the white cells. So here is a neutrophil, and here is a lump of black pigment. So where does it come from? The parasites aren't in the white cells. So this has come from, imagine a schizont of falciparum, 18 to 20 merozoites. The red cell was ruptured. Okay, all of those merozoites are now in new red cells. And there's this bit of pigment, this debris. And your phagocytic cells come round and mop it up. So we can sometimes see pigment in white cells. Sometimes that's all we see. And if we see it, it hasn't come from anywhere else. We then get back from the lab to the clinician and say, can we have some more films? Because this indicates that we've definitely had some malaria here. So you might just see the pigment in the white cell. Okay. All right, so here is a film that came into the lab. It was quite scanty. There's one parasite just there, in case you can't see it. It's a little tiny trophozoite. Took some time to find. Okay, it was very scanty. So this is a thin film. So a thick film is essentially a concentration technique. So tomorrow you're going to make thin and thick film. So you make a thin film, 1 drop of blood, and you spread it out in a monolayer. A thick film is 2 or 3 drops of blood over a small area. So it's like a stack of red cells. But you couldn't look at it because it's too thick. So what we do is we lyse away the red cells and we end up with naked parasites sitting on a background of debris. So this is what a thick film looks like. So the thick film, we looked at some yesterday with the microfilariae. You can still see your white cells. Okay, see the white cells? These pink fluffy things, they're all platelets. We've got lots of platelets. And here I put my arrow, there's a parasite there. Now this is the same blood as the thin film I just showed you. So we've got one parasite there, there's some more parasites, there's more parasites, there's more parasites. Okay? There's lots of parasites. So a thick film is a really, really good method of screening. Okay? Why would it be difficult to do a species diagnosis? Why would that be more tricky? What do you think? Exactly. Perfect. Can't see the red cell. So you can't say, is it enlarged, not enlarged, filling the cell, not filling the cell, etc. In most labs, certainly the UK, they don't look at thick films. They make them, stain them, and then throw them away. They look at the thin film, don't do the thick film. They only look at a thick film if they can't find anything on the thin film. But it's actually really quick. You can screen it very, very quickly. And with practice, you can do a species diagnosis. So.
But in the last slide, the parasite is the small purple point.
Yeah. Exactly right.
It cannot be nothing else, only the parasite.
Can only be the parasite. Well, you can just about see, I don't know if you can see with this one, there's a point there and a little tiny ring. You're going to look at a thick film, don't worry, you'll see down the microscope. Trust me, all right? You've got to trust me this afternoon. So, okay. You know what that is. This is a thick film. What's that? Yeah, falciparum cubitus. That's all right, isn't it? Good. All right, so what do you think this is? This is another thick film. Okay, that's a white cell, that's a white cell, that's a white cell. These three are parasites. Vivax, yeah. Why do you think it's Vivax? Yeah, exactly. So, yeah, perfect. So you've got these really untidy looking parasites. You've got a hint of pink around them, like a skirt. Okay, that would be the dots. And if you look at the size, they're almost as big as the white cells. So we've got an enlarged cell. So there are clues to look for, all right? So What about this one? Can you see that one over there? Any guesses on this one? Ooh, ovale. Why is it ovale? Yeah, it looks slightly, and it's a shape, isn't it? Yeah, exactly. So it's a slightly oval shape. It's got the dots, but it's much smaller than that, isn't it? It's a tiny, tiny little thing, little trophozoite. All right, so no real prizes for the next one. What's this? We've had 3 of them, so which one do you think this might be? Oh, well done. Yeah, so this is Plasmodium malariae. It's a schizon. So you can actually count the merozoites. So we've got 8 merozoites. We've got some yellow pigment. It looks quite small compared with this white cell. So you can do a species diagnosis. It just takes a bit more practice, okay? You have to be really confident with your thin films and then have a very good imagination to translate that onto your thick films. But it is useful even if you just say, I know that's a parasite. Okay. The thick films are good. Now, in all of this, I haven't really mentioned Plasmodium knowlesi. So we've gone through all those lovely morphological features, and I haven't mentioned knowlesi at all. So we can't miss knowlesi out, but it's quite tricky, okay? So how are we going to do a morphological diagnosis of knowlesi? And the problem is it looks like the other ones. So this is Plasmodium knowlesi, young stages, trophocytes and rings. So if we look at all of these, the red cells are all normal size. Yeah? So it's okay. This one looks like headphones. Yeah? Looks like headphones. Okay? This one is very neat. Oh, it looks like it's got Maurer's clefts. It's got those few dots there. We've got the same happening over here. It's a tiny, delicate ring with what looks like Maurer's clefts. Okay? We also see accolade forms. Okay, not uncommon. So it looks just like falciparum. The dots are called Sinton and Mulligan's dots. It doesn't really roll off the tongue, not like Maurer's clefts. They are slightly different, but they look just the same. So it's really hard to say that this is knowlesi. You would diagnose this as falciparum. We would diagnose this as falciparum. It looks like falciparum. So, more mature trophozoites. Let's have a look at those. So this one, quite chunky. Looks like it might have some Maurer's clefts. This one, we've got multiple infection. Okay. Could be falciparum again. This one, what does that look like? It's a band form, isn't it? Yeah? This one looks like a bird's eye. Okay, so we've got multiple infections. So these look a bit like falciparum. This looks like a band form. This looks like a malaria, slightly shrunken cell. This looks... So now we've got trophozoites that look like falciparum and malaria. So, quite difficult. Moving on to the schizonts. Does it become any clearer once we get to the schizonts? So they fill the cell. So that's good. So that might cut down your options. So they fill the cell, and when mature, they have 16 merozoites. Because they fill the cell and it's unenlarged, they do look a bit like malaria, but there's too many merozoites. That would be one thing you might be looking for. However, they don't always look like that. Sometimes they look like this. Okay, so what does that look like? Does it look like malaria? No. It looks like ovale, doesn't it? Yeah, it looks just like ovale. Okay. And then sometimes it looks like this. So if this was me, and I was a betting person, I'd put money on this being falciparum. Absolutely. Lump of black pigment, doesn't fill the cell, looks like it's got Maurer's clefts, got a couple of trophs around here. Yeah, it's falciparum. Knowlesi. So it's now looking like all species. Okay, schizonts could be anything. And then we have the gametocytes. Wow. Gametocytes, when they're mature, they fill the cell, so it looks exactly like malaria. This one, 3 or 4 parasites. Could be falciparum there, those trophs, but our gametocytes look just like malaria. They've got scattered pigment. So you can see the diagnosis of Plasmodium knowlesi is really tricky. And this is really where the PCR comes in. Microscopy, it's not really going to work at all. RDTs, They don't work either. Sometimes they do, sometimes they don't. So it's not so good. So PCR, this is where we use PCR certainly for the cases that come through our lab. As experts, we kind of feel that it looks different. So for me, if I see a Knowles eye, it looks like Malaria with Maurer's clefts, you know. If we get a travel history, we don't always, but if we get a travel history, that can help. So anything coming from Southeast Asia, from the right region, we do PCR on anyway. I have to say, we have missed one. Out of all the time, we missed one because it came in to us, query falciparum, no travel history. We looked like falciparum to us, sent it back, yes, falciparum. When we did the surveillance, it came up as Knowles eye. When we got back to the submitting hospital, patient had been to Borneo. So if we'd have known about the Borneo before, we'd have done PCR straight away. So it's really important that you get these travel histories, okay? So that's Knowles eye. Nearly there. So how well you can do a morphological diagnosis depends on a number of things. Depends on your films, okay? So thin films, you have to make them well, but they're not as sensitive as a thick film. But the thick film is more difficult to do your species diagnosis. So they both have a role to play, which is why we always like both, thicks and thins. Stains you use, that's important. You need to use Giemsa. You need to make sure you quality control your stains. You know, don't just assume it works the same every time. You need to be batch testing. You need to make sure that it stains for the same every time you use it. pH, you might consider that you change your pH. So we always use 7.2, but you might be using 6.8. So you need to think about some of those features that they may or may not be there. So considering how pH has an effect. Anticoagulants. Now, I haven't talked about anticoagulants because I haven't got a lot of time. If you take venous blood into anticoagulant, the one you need to use is EDTA, right? That's the one to use. However, the longer the blood is in the EDTA, the more effect, the more detrimental effect that EDTA is going to have on your parasites. The bigger the cell, the more it affects it. So things like Vivax, late stage of Vivax, are most affected. Falciparum, least affected, so that's really good. But what it can do is it can make things look very condensed. It can make them explode. It can make male gametocytes exflagellate. They think they're in the mosquito. So you can see all sorts of strange things going on. So it looks, the picture starts to look different. Okay, so storage in anticoagulants is not great. You need to make your films relatively quickly, ideally within a couple of hours, 2 hours of taking it into the anticoagulant. After that, you'll see progressively more effects. Obviously, if you're doing it from a finger prick, that's fine. Of course, this is the big thing, isn't it? Experience, you know? I can tell you all of these things, but you have to look and look and look, you know? You have to be a little dinosaur there, you know, having a good old look at the malaria parasites time and time and time again, because it is about you being exposed to them and seeing them lots and lots and lots. So for us in the lab, when we train our staff, we're training an expert, because we're supposed to be the experts. We'll take up to a year to train someone before we let them loose, you know. In a more sort of routine lab, obviously your training is not going to be that long. So you've got 2 days, no problem, okay? So we are going to look at these things, okay? We are going to look at the size and the shape of the red cell. We're going to look at the inclusions in the red cell, yes? Schaffner's dots, Maurer's clefts, all over, not all over. We're going to look at our parasites and decide whether they're neat or untidy. How much of the red cell is occupied? All of it? Small proportion. We're going to look at schizonts and count merozoites. And the last thing we'll do is we'll look at the pigment. But no one feature outweighs all the others. So you have to look at a kind of global picture. Have to add all those features up. Okay? So I've got lots of films. So we're going to do one film like we did yesterday. We'll do a film together. I'll show it on the video. And we'll do it like that so that everybody keeps up. We're also going to do, as the afternoon progresses, some counting. So parasitemias as well. But we'll start by looking, getting your eye in. Okay? Any questions? No? Good. Right, so we will start by looking. So we are going to use the oil immersion lenses today. So you're going to need to use oil. So what you need to do is you need to focus on the slides using your ×10, the yellow lens. And then when you've got it in focus, go on to 40, check the focus, and then go onto the oil. So if you're not sure what you're doing, make sure you ask one of us. And my first slide, I'm not letting you see the answers. Everything's coming as an unknown. Mm-hmm. Yeah, sure. There we go. I'll leave that up and then you can refer to it. Okay. So the first slide is labelled H10. Doesn't mean anything but just H10, okay? So have a look at H10 and see if you can make a diagnosis. So look for all of those features that we talked about. Yeah, you're going to have... Oh. There we go. Okay, so focus first on ×10 and then focus on 40. You need to make sure you've got lots of light. And then onto your oil. I think everybody's got some oil. But ask questions. We'll come round and make sure you're all right. Particularly those of you who've not looked at much malaria. Okay, so how are we getting on with this specimen? Have you all got a diagnosis? Everybody decided what they're looking at? Do you need more time? No? Easy one? Okay, so what is the diagnosis? Falciparum. Everybody agree? Anyone not agree? Good. Or you're not saying, even if you do, I know. So what stages did you see? Just the rings. Trophozoites, yeah? Anyone see anything else? Any schizonts? Any gametocytes? No? Good, because there weren't any. Good, just checking that you weren't making it up. So, I'm going to show you on the video, on the screen, the things that I wanted you to see, and then we will move on. So let me just get rid of that one. Okay, so this is on ×100. So I'm going to try and make it a little bit bigger without losing too much resolution. Okay, so you can see this parasite here, this red cell here. So we've got two parasites in the one cell. If we're looking at this cell and the ones around it, we can see it's the same size. We've got a parasite here, a trophozoite right on the very edge, so that's an accolade form. And inside the red cell, I can see a few slightly sort of blue dots, but only a few of them. And these are the Maurer's clefts. Okay, so did everybody see Maurer's clefts? Yeah, anyone not see the Maurer's clefts? Because we'll come and find some, because it's important that you see them and recognise the Maurer's clefts. So if you didn't find them, because they weren't in every cell, make sure you get one of us to come and have a look with you. So this malaria had some very nice, neat parasites. This is a good example of a very nice, neat-looking trophozoite here, very sort of perfectly round with a few Maurer's clefts. There were Accolaiforms, there were multiple infections, and there were some headphones as well. So you should have seen all the things, all those features that we talked about. Oh, this is a lymphocyte, yes. Yeah, just checking, that's sort of dark purple. You can see it might be confused with your Plasmodium malariae. Let me just show you something else in passing. See this? Giant platelet. Okay, so it's not uncommon in malaria to see giant platelets because you get suppression of the bone marrow, so you get production of immature platelets. And sometimes these platelets can be red cell sized, so they look like malaria gametocytes and things. So just make sure that when you're looking at your parasites, it has all the right features. This is just going to be pink, okay? So, everybody happy with that first one? Yeah, good. So, are you ready for another one? Yeah? So, keep hold of that slide because we're going to come back to that. And the next slide is slide F. Okay? So, slide F coming up. If you didn't see the Maurer's clefts, make sure you get one of us to come and show you some Maurer's clefts before you go on to slide F. So same again. Do it on 10 and then go up to times 40 and then onto your 100 to look for the features. Better. On the left is a lymphocyte, but on the right, see it's more delicately coloured, so I think parasite. So starting at the outside, is the red cell enlarged? Yes. Yep. What stage do we think this is? So here where that cross is the nucleus, and then just below it, can you see there's a space? And then we've got all of this, which is cytoplasm. So I agree. I think this is a very mature trophozoite. It's still got that space between the cytoplasm and the nucleus. So it's almost a gametocyte, but not quite. So I think very, very late trophozoite. You don't need to know kind of the finer detail. But it's almost filling that cell, isn't it? So it's big, and we've got some dots just here. It's also moulded. It's quite plastic looking, isn't it? It's an odd shape. So that's another feature. So I'm still thinking Vivax. You agree? Yeah? Still thinking Vivax. Right, good. Let's see what else we can see. So here we have another red cell with a parasite in. I can get it to... There we are. So what have we got here? So starting at the outside again, is the red cell enlarged? Yes? What do we think in terms of stage? So this here is the nucleus. We've got lots of cytoplasm. It's rather untidy, isn't it? So what do you think? Trophozoite or gametocyte? Trophozoite, good, yeah. It's a trophozoite now. It hasn't got as much cytoplasm. It isn't filling the whole cell, but that's okay because this is a developing trophozoite. It's quite mature, but I can definitely see, would you agree, dots all over the surface of the red cell. Very even. So this is looking like quite a nice Vivax trophozoite. So everything I've seen so far looks like Vivax. So let's have just a look around just to check there's nothing else. So this here is another parasite. So this time, it's not it's not a plastic one, it's just sitting on its own, but the red cell is enlarged. Stage, what stage is it? All right, hands up if you think it's a trophozoite. Be brave. One of you. I think more than one said trophozoite. 3 of you, okay? So the rest of you, what do you think? Gametocyte? Hands up if you think it's a gametocyte. Yeah. Shy's on, hands up. Okay, so it is, I've got a single nucleus here, so it can't be a Schizon. It's completely solid, so there's no space here, so it can't be a trophozoite. It is a gametocyte, okay? So it's completely filled in, quite solid looking. So this is a gametocyte. It's in a very enlarged cell. It's filling the cell, isn't it? It's big, just a hint of dots around the edge. So vivax gametocyte again. Okay? Did you all get that this slide was vivax? Yeah? It was a bit more tricky, wasn't it? Because there were lots of different things to see. So there were trophozoites and gametocytes in this slide. That's what we were looking for. Everybody see both trophozoites and gametocytes? Yeah? If you didn't, we'll come and help you find them. Ready for the next slide? Yeah? Okay. Okay, so the next slide coming up is J6. Not that one. That one's broken. Oh. Okay, so have a look at this one. What are we doing with this slide? Have you all found parasites? Yes, everybody found something on their film? Yeah? So if I go through it on my slide here, so we have two things here. This one on the left is a neutrophil, okay? It's got dots, but it's not quite right, a bit too dark. So this one is definitely a parasite though, okay? So, first thing, is it enlarged? Red cell enlarged? Little tiny bit, yeah. What about the shape? Oval, yeah, it's elongated, isn't it? Is it spiky? Yeah, it's a bit spiky, isn't it? So already, we're already thinking of ovale. So, what is the stage? Oh, that's always a tricky bit, isn't it? So there's a single nucleus here. So what's the stage? Gametocyte, very good, because it's solid. Okay, there's no hole, so it's not a trophozoite. It's got one nucleus, so not a Schizon. So, has it got dots? Lots of dots, and they're a bit coarser, aren't they? They're bigger. It's not very clear on here, but they actually looked a bit studded. So they're big dots. So we've got dots. So it could be vivax, could be ovale. Slight enlargement, more likely to be ovale than vivax. Oval, bit spiky, definitely heading towards ovale. Doesn't fill the cell. Ovale. Yep. So this first parasite, I'm going with ovale. So you need to look at more parasites. We can't make it on the first thing we see. So I've got another red cell here with a parasite in. So this time, is my red cell enlarged? Yeah, I think it's enlarged, that one, maybe. And it's round, so there's nothing to help there with shape. It's got dots. It's another gametocyte. This time it's not quite as neat. It's a little bit untidy. So, would you say ovale or vivax? That one parasite there that you're looking at? Honestly. Vivax, yeah. I would say, well, it looks a bit more like a vivax. So I've got one parasite that I'm thinking ovale, one parasite I'm thinking vivax. So I need to find more. So we'll see, we've got lots of lymphocytes. Okay, so we've got a very nice parasite here. Okay, so enlarged or not? Red cell enlarged? Little tiny bit, isn't it? Less. So dots, any dots? Yep, all over, bit coarse. What stage is it? It's got a single nucleus, yeah, which is kind of up here. So gametocyte, is it filling the cell? Definitely not. So what do you think for this one? Ovale or vivax? Yes, ovale, because it's not filling the cell. So even though it's not oval or spiky, it's not filling the cell. It's so perfectly round. This one for me is ovale. And in fact, this slide is an ovale slide. And it's very difficult sometimes to tell vivax and ovale apart. So always we look at a lot of parasites before we decide, do most of them look like vivax or most look like ovale? Sometimes in the reference lab we can't decide. We call them ovax, okay? Because we can't make our minds up. So this one is ovale. So did you all think ovale in the end? Yeah, some of you? Yeah. All right, so I've got a slide for you. Now, no surprises what you think this might be. You know, we've had 3, I'm just saying. So I wonder if this could be something exciting. All right, so have a look at this one. And then we're going to do a count. Okay, so have a look at this one first. So I've got a parasite on the screen here. What stage is it? Schizon, yeah, it's got lots of nuclei. So in all of the other slides we've been looking at, and some of you have been saying, oh, is this a schizon? It's not a schizon. When you see a schizon, it's very clear, isn't it? The nuclei are very, very distinct. So if you don't see distinct nuclei, it's not a schizon. You have to see those distinct ones. So this is lovely. So we've got 1, 2, 3, 4, 5, 6, 7, 8 nuclei. Really nice. And I don't know, have any of you been looking and seeing pigment? Have you seen the pigment, the yellow colour? Yes, some of you have. If you haven't, this is a really nice example of the pigment. It doesn't show so much on the monitor, although there is some sort of yellow colour just here. So what I'll do is I'll leave this one up, and then you can come and have a look. So this was a red cell that is slightly smaller. Would you agree? Yeah? It is a schizont that has 8 merozoites, and it's filling the whole cell. So what is your diagnosis? Malaria, yes. So there were gametocytes, there were band forms, and there were schizonts, and there were trophozoites. So it had all the stages in this one. This was a very beautiful slide. So are you happy with malaria? Yeah? Right, so we are going to do the tricky thing now. We're going to do a count. So for falciparum infections, you want to know what parasitemia is, don't you? As clinicians, you all want to know. You'll be asking the lab, what is the parasitemia of this falciparum? So why do you want to know what the parasitemia is? Oh, very good. What's the reason for the parasitemia? Why would you want to know? Yeah, degree of severity, yeah? So a patient can be very poorly and only have a low parasitemia, but it's more likely that if the parasitemia is high, then it will be more severe. So why else do you want to do a parasitemia? Do you just do it once, or do you do it multiple times? Multiple, yes, because you're going to follow and make sure your treatment's working, that the count is coming down. Okay, so we need to do a count because the count is going to direct your treatment and just check that everything is okay. So we only count Plasmodium falciparum and Plasmodium knowlesi. So now we have added knowlesi to the species that we must count, because with knowlesi, numbers can increase very quickly because it's a daily fever pattern. Yeah. So There are many methods to do this, but the method that is recommended is to do a parasitemia that is expressed as a percentage. So you are going to count and tell us how many red cells are infected. Okay, so it's about infected red cells, not numbers of parasites, infected cells. So it's the number of infected cells as a percentage of the whole. All right, so if you had 3 parasitized red cells in 100 red cells, that would be a 3% parasitemia. Yeah, that will sound fairly straightforward. If you have more than 1 parasite in a red cell, we still count that as 1. So that's 1 parasitized cell. We don't count gametocytes because clinically they're not important. So we're just going to count the asexual stages, okay? So what you need to do is you need to count quite a number of red cells. So you need to count 2,000 red blood cells, okay? So in order to count 2,000 red cells, we're going to do an estimate. Because you could do it, 2,000 exactly, but we generally estimate it, and that's good enough. You need to know whether it's 5% or 0.5%, so it doesn't matter. So to count 2,000, you're going to count a number of fields. Now, I'm guessing that you've got about 250 red cells, 300 red cells per field here, okay? We're going to say 250 because it makes the maths easier, all right? So in a field, when you look down that microscope, on times 100, you need to look at a field where the red cells are laying side by side, okay? And in those fields, you've got somewhere between 250 and 300 red cells. So if you were to look at a field like this, that's not good. Neither is this, okay? So this is too thin, this is too thick. What we need is something like this, where it's even. This is just right, okay? So this is just right. So imagine we're looking down the microscope, so it looks a bit like this. So we've got one field. This is one field of around 250 red cells. So we count the number of parasitized red cells. So we've got 1, 2, 3. So that would be 3 in 250. So we are going to count 8 fields that look like this. Okay? So you count 8 fields going down. If you go across, the red cells will change, won't they? It will get thicker or thinner. So you go down, 8 fields like this. So how do I know when it's a field? Well, we look at this red cell here and we watch as we move until it disappears. So we're going to count. I'm going to try and do it on the video with you, just to give you the idea, okay? So it's not quite straightforward. Right, let me just change this. Is it that one? Yes. Very good. Right, so we're going to do this on slide H10. So just bear with me while I put the slide on and find the right sort of area. So we need to find the blood film first, would be good. There we go. Right, so this is okay. So we've got a few gaps, a little bit overlapping, but generally it's fairly even. So this is my first field. So how many parasitized red cells have we got here? So I've got 1, 2, 3. Agree? 3? So that's 3 in 250. So I'm now going to watch this cell here until it disappears. So, oh, hold on a second. It's very sensitive, this. Also, it's moving slightly wonky. Right. We'll say 3. Right, imagine it's gone. Okay, I cannot move it slow enough. 3. So then we look at the next field. So we've got 1, 2, 3 again. So that's 6 in 500, yes? 2 lots, 250. So just pretend. Oh, it's another field. 6, so now we've got 1, 2. So that's 8 in 3 fields, 8 in 750. Next field. Okay, I'm getting a bit thick. There we go. So we've got 1, 2, 3, 4, 5. So that's 13 in 1,000. Yeah, because we've got 4 fields. So we're going to carry on doing that for 8 fields. So then, let's say I've now got, I don't know, let's say 28. Just for 28. So I've got 28 parasitised red cells. So parasitised RBCs in 8 fields, yeah? So that's the same as 28 in 2,000 RBCs, yeah? So we want to say how many in 100, because 100 will be a percentage. So you divide 28 by 20. Now, I can't do that in my head, and I'm not going to get a calculator out. You can do this, maths. So what we do is we half it. So what's half of 28? 14 in 1,000, yeah? So that would be the same, 28 in 2,000 or 14 in 1,000. We're then going to divide by 10. So we've got 1.4 in 100, yes? You with me? Therefore, the percentage is 1.4%. Okay? Over to you. You've got 20 minutes. I've got 2 for you to count. Do you think you can manage 2? We'll try 1 anyway. So, count H10, and we'll see what we get as a class. Okay? If you're not sure what you're doing, ask. If you want us to have a look and check you've got the right field, ask and we'll come and check. Okay, so slide H10, which was the falciparum slide we started with, that's the one you're going to count. Okay, clock's ticking. Those clinicians are waiting upstairs. They're saying, where's my count? Okay, so everybody's seen parasites on their thick film? Yeah? Think you could find them on a thick film again? Yeah. Yeah, I hope so. I'd hope so too, yeah. No, not lucky, skilled. Skilled. Yeah, I think, yeah. More practice. Okay, so unfortunately, we have to stop there because you've got another lecture at 4 o'clock, so I don't want you to be late for your lecture. So I hope that's been a good introduction. There's going to be more malaria tomorrow. So you've got your eye in now. You can count now. Very good. Well done. So if you make sure you clean your lenses, please. Your times 100. Make sure you give it a good wipe. Take the oil off. If you leave the slides, I'll come round and collect the slides. Pop your microscopes away, because I don't want you to be late for your 4 o'clock lecture. And we'll clear up, and I will see you tomorrow. Yeah? No, I'll do those, don't you worry. I'll clean the slides. Bim and I will clean the slides. Yeah.
Don't worry.